As far back as 2009, studies had shown that nearly 75% of patients hospitalized for myocardial infarction, commonly known as a heart attack, had cholesterol levels that would indicate they were not at high risk for a cardiovascular event. And that was based on the current national cholesterol guidelines way back then. Now, in 2017, an article in the Journal of the American College of Cardiology found that 50% of participants in a study that were between 40 to 54 years old and were in ideal health, as defined by normal blood pressure and blood sugar, had significant arterial plaque buildup despite normal cholesterol levels. Despite this information, the standard of care in most clinical settings to run what we know as the standard lipid panel that is simplified into good and bad cholesterol. So I wanted to bring Dr. Paul Anderson back on the show to help us make this make some sense and discuss how you and your doctor can look beyond the lipid panel to assess your cardiovascular risk and health. Now, Dr. Anderson is coming back to the show. I'm very excited about this. So let me tell you how awesome he is. He is an esteemed educator and clinician in integrative and naturopathic medicine, focusing on complex infectious, chronic, and oncological illnesses. With over 3 decades of clinical experience, he founded Advanced Medical Therapies in Seattle, Washington for cancer and chronic diseases and still collaborates with various clinics and hospitals to this day. He's held positions at multiple medical schools, including professor of pharmacology and clinical medicine at Bastyr University. He's also authored several books and articles and is actively involved in continuing medical education through online platforms and conferences. And if you are a naturopathic doctor, you have most likely benefited from the board study guides and many platforms and videos that he's put out there. So you can basically, I always tell some people, it's like if I say something, blame Paul. Blame Paul. You blame him. This is, if I drop a curse word in the middle of something, just blame Paul. This is how I was taught. So welcome back to the show.
Thanks so much for having me.
No, man, this is a pleasure, man. It's always a pleasure. So I really want to get into this here because, to understand, before we get into the deep dive here, we need to understand the basic cholesterol panel, what people are getting, right? So when someone goes to their doctor, whether it be for the first time, they're going to say, yeah, I need you to fast. And I want you to come to these labs, right? And you're going to get a lipid panel and they're going to check some basic things here, like your cholesterol. Makes sense, right? They're going to check your HDL, LDL, VLDL, and triglycerides, and they're going to tell you what's good and bad. So when they're talking to us, talking to the patient, what do those terms mean? Because we're kind of taught cholesterol is this bad thing, right? Oh, you got cholesterol. So bad. But then you read a book and you realize, wait a minute, I can't make hormones without cholesterol. I can't even take a poop without cholesterol. So let's talk about that. What are we getting in that basic lipid panel?
Yeah, it is one of those mixed message things. And I think where it comes from is in an effort, especially you go back like, 30 or 40 years ago, in an effort to try and make something that's complicated simple, they kind of went a little too far towards simple. And so it was cholesterol bad, right? Well, as you said, all of your steroid hormones, the name steroid comes from sterol. They're made from cholesterol. So is your vitamin D. A whole bunch of things are made from cholesterol that we need to keep running, right? So cholesterol isn't bad. It's just one of those things in our body. It's got lots of little subfamilies, and either through diet or genetics or time or some combination of those, the subfamilies can either become more healthy or less healthy. That's kind of how I talk to patients about it. Now, it's not that long ago in, certainly my lifetime, where they used to just report total cholesterol. Actually, that's all the number you got, right? And then they got these better panels where they did HDL, total cholesterol, and then LDL, and then triglycerides. So that was kind of your basic panel. So you got a total number, and then you got HDL, which is, so well, that's probably the good one, the H one, and then LDL, well, that's the bad one, right? And then triglycerides, well, those mean something else. Now, as you mentioned in the intro, they do these studies, and even I remember 30 some years ago, studies coming out saying, look, over half the people that have sudden heart attacks have totally normal cholesterol. Like everything looks good on their labs. So there has to be a deeper level. And so your standard panel that we normally see in primary care is that basic panel. It's total, and then the HDL family, the LDL family, and then triglycerides. And then often along with that, they'll look at your blood sugar, like a hemoglobin A1C, because now we at least uh, realize those are all connected to one another, right? But the problem, as you said, with even the newer studies now that pretty much say what they said for the last 30 years, there's a lot of heart disease we don't catch with that panel, obviously, right? So there must be like a deeper layer of chemistry with these cholesterol molecules. And there must be something where not all HDL is as good as others, and not all LDL is as bad as others. Okay, which does be that's the truth, actually. So then, that leads us to these more modern sorts of lab protocols that we can run. But as you and I talked off air, they're not run that often. And so I think what we're going to talk about today is we've got a lot better science, we got a lot better technology to measure this stuff. Why don't we look at this deeper level of chemistry and maybe help more people not have these problems in the future?
No, and that makes sense. So you kind of mentioned something, and I kind of said it a little bit earlier too, is there, this is a complicated kind of question here, right? It's like, is there a such thing as when they run that lipid panel, like, hey, your HDL is 60, this is good cholesterol. LDL is 98, that's bad cholesterol, right? But is it that simple? Right. So can we even say this is a good and bad cholesterol, or can we just say, hey, this is what your values mean, but I need to look deeper?
Right.
So,
Yeah.
I guess a better question is, should we stop saying that? Should we
Yeah.
stop saying good and bad?
Good and bad. Yeah.
Yeah.
I do think part of it, is maybe PR, and people, you know, they want a really quick way to tell a patient good, bad, right?
Mhm.
But as we know, like 50% of the time, it doesn't predict anything about heart disease.
Right.
So yes, in my opinion, we need to look deeper because we have the technology to look deeper at a much better, level. Now, I will say, just there is he's passed away now, but there's a researcher named Fredrickson who originally said they knew about this, but we didn't have the lab technology to figure all this out that we know now. And this Dr. Fredrickson and his whole team, that was their whole life's work, was cholesterol and getting this deeper level.
Mhm.
And even back, he started researching in the 50s and 60s and started publishing in the 70s and 80s, came up with something that he called the Fredrickson's phenotypes. And those were the next way to get to like deeper levels, right? So like even back when you took your clinical board reviews, the old man who talked about your clinical board reviews had Fredrickson phenotypes in there, and some of these technologies. Well, what happened then is, like everything with laboratory stuff, we get better equipment, we get better ways to look at things. Now we do nuclear test, NMRs and VAPs and all these good things. Well, the other end of the story now in modern times is we can actually see that what we called LDL, quote unquote, on your good cholesterol number, that divides up into a whole bunch of other things. Okay. So LDL is not all one thing. There's different sizes, there's different inflammatory capabilities. Same with HDL. It's not all, some of it's better good than other, right? So these more modern tests basically they take you down to the next level. And so the first thing is, if you look at a acronym and it just says LDL or total LDL, or you get a newer test that says LDL-P, what the P means is they actually counted the number of particles. Okay. And you think, well, I got a number on my old fashioned LDL, 104 or whatever. With these modern tests, with the better technology we have, you actually get the particle numbers. And so I would tell patients, it's sort of like if you have a, glass jar, like a big glass, gallon jar, and you pour a bunch of marbles into it, you can guess, if you've done that enough, roughly a gallon jar is going to hold 100 marbles, right? Well, what if the marbles are of different sizes? I'm still going to call it a gallon jar, and that's the old-fashioned testing. That's going to be, 100 or 150, whatever. If I take all of those out and count them, it might be 92, it might be 190. and they all
Mhm.
fit in that gallon jar. So it's really it's like a whole different world of testing. So if your test reads with a P after LDL, it means they actually counted the particles either with modern times vertical auto profile or an NMR.
Mhm.
And it doesn't really matter to the patient because it's the lab's choice what tech they use. But the important part about that is then when they count the particles, then they'll fractionate them and they'll say, this is the percent that are large, medium, and small. Okay. This is where the not all LDL is as bad as other LDL comes from, right? So if I've actually counted the particles, like I LDL-P, then I go in and I look and I, win the genetic lottery, and then I've got, mostly large LDLs. Those are least likely to create trouble for me. But what if I don't win the genetic lottery, or maybe my diet or other things going on? I will have a lot of small ones, and the small ones are super inflammatory, and they're associated with like literally beating up the insides of your blood vessels. So they're
Mhm.
not so good for you, right?
Right.
Same with HDL. If it's a total HDL or HDL-C, that's the old fashioned kind, just sort of how big is the bucket? HDL-P is literally the particle size of HDL, and they'll subfractionate those as well. So that, I think it's important because it's the same name, but
Mhm.
it's not the same product coming out. So people will say, well, I got HDL done. Well, it's like, yes, you got like the 1979 version of the lipid panel.
Mhm.
and we can do the, 2020 version of the lipid panel. It's a same names, different
Right.
outcome. And I think what's important is, and there's tons of other little, things on these panels, but then we can actually look and say, oh, there's, this person's much less likely to have that amount of LDL be a problem. This person, they're probably one of those 50% of people who might get in trouble. So then we
Mhm.
can intervene. And I think
Now,
that's where it makes our job better as doctors, but then the patient's safer.
Now, something you mentioned, and we're going to get into these more detail here. And we're going to do a little round robin. I'm going to throw a lab at you and say, what does this mean? Right. We're going to get to that. That's going to be the fun part. Right. But for patients, right now, this is the part where, okay, if you tell me, hey, I've got an LDLP, this particle size, right. And you're going to tell me that, hey, I got 2100 for my particle size. That means I got a bunch of little particles. Right. And so, but if I have a smaller number, or if you kind of do that fractionally, you're saying, hey, these are bigger particles. Now, most people will assume that a bigger particle is worse, right? Like, wait, it's big, it's in there. Can't that cause like a blockage or something like that? Why are
Right.
shouldn't the smaller ones be good? Like, how does
Yeah.
that make sense to have
Yeah.
like the smaller is worse, right?
So, and the very first time, like when we were transitioning from the Frederickson technology over to NMRs and things, the very first time I heard about small versus large particle, I actually thought the same thing, just logically, oh, big must be bad, right?
Right.
So one way, or back in the day when they were trying to teach all of us doctors how to sort this out, is that think of it like this: like a large fluffy LDL particle sounds bad, but it's actually more stable. And so it will go by and it doesn't really want to interact with your blood vessel walls. Whereas the little particles are unstable, and that means that they have more reactive oxygen, more, free electrons, more reactive oxygen damage, and they actually like to go and kind of stick because they're little, like sort of like buckshot, right?
Mm-hmm.
So, and that actually, if you take it to the next step and make it, a little less ground floor, what really happens is that you have this really elegant system in your body where HDL and other factors go around, and what I say is they organize the LDL. So LDL is made by your liver, it goes out, and over time, then it gets organized into, from these free small parts that have a lot of reactive oxygen damaging stuff to them, and then the HDL can come around and trade lipids so it gets bigger and more stable. So you actually want bigger and more stable when it comes to LDL. And so like when I said you lose the genetic lottery, maybe there are people whose genes don't allow that transfer very quickly. Okay. So and sometimes just your diet is really inflammatory, or maybe there's other issues. But that's if you if you do get this type of test, if they make comment on LDL, they probably will at least say, oh, well, most of yours are the large non-damaging kind, or, oh, most of yours are the small damaging kind. We need to work on that, right? So
Right.
that's kind of the small versus large when it comes to LDL anyway. And it's about how organized they are. And another thing, so we say HDL is good, and to a degree it is. There's more than one kind of HDL. There's one HDL though, I always think of it as the best HDL. This is the do-gooder sort of HDL. It roams through your body and it trades inflammatory fats for non-inflammatory fats. Okay, which is really cool. Well,
Right.
if those are real active, then you tend to have LDL that are stable and not inflamed. If those really do-gooder sort of HDLs are very inactive, then you tend to have much more inflammatory fat activity, and that leads to cardiovascular disease. So, one of many things, of course. But yeah, that's as simple as that story gets.
Right. Yeah. And we're going to get deeper into that as we go forward. Now, one of the things that let's kind of allude to that original thing about that 50% of people with the normal cholesterol levels. Let's say you're a guy or girl, you come in, it's like, hey, my cholesterol's been good my whole life. I've never had an issue. And I guess the better question to ask is like, hey, is this, if you have normal cholesterol, what should trigger your doctor to say, hey, I want to look a little bit deeper. I want to look at this just besides the numbers, right? Because we know that the facts state that this can happen. But should we be looking at their lifestyle? Should we be looking at their family history? I mean, I guess a better way to ask that question is we have a patient, they've had normal cholesterol since you've been seeing them over a period of years, and you've never run this deeper look. Should you? Or is there kind of like a
Yeah,
little trigger point to say, yes, I need to run this just to get the warm and fuzzy kind of feel?
right. Right. Well, I think you kind of, like we do with everything else, you kind of have to stratify it. The
Mm,
way I have always looked at it, and I think more so now that we have newer technology and better labs, is if I have anybody who has a family history of cardiovascular disease at all, but especially if they have a big family history or a young family history, where, gee, my dad and my grandpa both had heart attacks at 55 or 50 or whatever, that person, it's not a debate. Like, they need the best well-rounded look into their cholesterol and their metabolism we can do, right? If somebody's otherwise healthy, they don't have a family history, their diet and lifestyle really are probably as healthy as they can be, I'm not really going to be too worried about that person until they get maybe past 45, 50, certainly into their 50s, because it's at that point where, once you crest, people do have heart attacks younger, certainly, but, once you get past 50, men or women, the stats just rise, really, really steep. So I think as part of just health maintenance and a baseline, I think either with family history or a long history of maybe a lot of damaging things, like your diet's really, maybe you've been healthy, but your diet's been horrible, for 40
mhm.
years, or you just had maybe other things, or toxic exposures or whatever. I think, yeah, we'll click you in earlier, but every human probably between 50 and 60, I think, if it's me, because that's what I get done on myself, I want to know as much as I can, because then there's things, some of this we can help with diet. Some of this we might help with, depuration and detoxification. Some of it we might do all sorts of stuff with. But if all we have is just a big old, rough number, we don't really know much from that.
It's true. It's true.
Yeah.
Indeed,
Yeah.
indeed. So now we've kind of established that, hey, these are important, right? We know there is a risk there potentially beyond these normal labs, right? And so now your doc's like, hey, I'm going to run this panel, make sure you're fasted. And that's important, right? Because obviously you want the patient to be fasted. And so, which kind of common sense, right? Because you make cholesterol when you eat. Fun fact, when I was a young buck in the Navy, I was horrible at fasting for labs. Horrible. I was like, I can't go that long without eating. It's at 9 o'clock in the morning. What's wrong with these people, right? And so I would not do my labs fasted, and I never had a spike in anything. Everything was normal. They're like, "Oh my God, your level's great." I'm like, "Yeah, I fasted." Wink, wink. Right.
Yeah.
And so there are going to be some people out there who can
Yeah.
show up and eat a burger and show up and have normal
Yeah.
cholesterol, right? And there's some people, it's like
Yeah.
they look at an almond and it's like, oh my God, your
Right.
triglycerides through the roof, right? But in general, we want to make sure our patients are fasted just so we get that
Yeah.
quick look. But people who are like that, again, this is kind of cool for me too. It's like, what happens when someone they don't fast and their normals are, or their levels are still normal? Are they just like you got the best cholesterol ever, or is it just kind of random?
Well, yeah, and that's a good example. Like, you or someone like you who has that history of I can do whatever I want. And
Before I was a doctor, by the way,
yeah,
I would
yeah,
never do that now.
yeah.
Patients
But
listening.
so I think there's a couple things, and
Yeah.
I will say, because I've heard this, and you can read this in the literature, the family practice community, primary care community, and in the bigger medicine, allopathic medicine, there's a big push to have non-fasting cholesterol. Now they're not doing these tests we're talking about.
Mhm.
They're basically just looking, at total cholesterol and HDL, LDL. And the reason for that is, partly they've done some statistics or whatever. But the other side of it is, what's their treatment going to be? They're going to give you a handout about diet that you're probably not going to read, and they're going to give you a statin, right? So their point is, well, if I'm going to give you a statin, if it's high, why would I care, right? Well, here's the now that we have people saying, should I fast?
Mhm.
What I will tell them is, look at the old tests like you're doing, that you've done your whole life. It's sort of like, a 1979, you know, Buick LeSabre or something. It's going to get around. It's not too efficient, but it looks like a car. You're paying for a brand new Lexus here. This is the version of this lab you got now. You don't want to throw anything off. You want this to be the product of just your liver and your metabolism overnight or however long you fast. And you want these to be clean numbers, because we're not just going to use this to say you need a statin or not. We're going to use this to say, wow, we need to have you exercise more. We need to have you control your blood sugar more, or whatever, it is. And so why waste, because these tests are more expensive too. Why why get a Lexus and then just wreck it right away, which is what, not fasting for one of these labs would be like.
Right.
Whereas your old LeSabre, you might back into something and not care. So it's sort of different world. Like, and
Mhm.
you got to remember that most of primary care now, some cardiologists do these labs, right? But most primary care is still doing the old testing. And so they don't care as much. So yes, please, if you're going to spend money on this type of testing, you want to be fasted,
Absolutely.
and
Absolutely.
just because it literally then is like, at my baseline, what does my liver and what does my whole body's metabolism actually do? Not what did
Mm.
I just eat, right? I
Right.
mean, I don't know if you ever seen it, but I had a lady one time, and she got her lipids done, and I looked at them and I was like, "Did you eat before you did these?" And she says, "No, no, no, I didn't eat." I said, "Did you just drink water, or do you have anything to drink?" And so, well, I had some tea. I said, "You put anything in the tea?" And she said, "Well, I put honey in the tea." And I said, "Well, that's not fasting then."
Yeah,
Her
you just ate.
triglycerides were like 800, and
Yeah,
it's like,
yeah, you just
because
ate.
she got this big sugar load right
Mhm.
before she got her labs done. So yeah,
Yeah,
just
that's
just
the hard
just
part.
just fast, folks. I know it's
Yeah,
rough.
it is.
Just
Yeah, exactly. Just fast, right? I know that was a long time ago. That was in the, I would never do that now. And again, so you hit on something that I definitely want to ask you about, and this may just be our, an opinion question here. If we have all this information and it's out there, this is not a secret. It's not hidden behind some vault in some, secret medical school in Vienna, right? We all
Sure.
know this, right? If and we know the risk factors. I'm gonna keep harping on that. So many issues happen with normal cholesterol levels. Why isn't this standard of care? The first time I see you, I should run this, right? Just knowing what we know. Is it,
Mhm.
I guess the question is, why do you think we don't do that as a medical community?
I think, well, I'm going to answer this is my opinion, observing medicine for a very long time, especially the North American medical model loves certain types of statistics because it helps them only deliver the minimal amount of care to treat the most people. Okay. And you can kind of see, if you have a cap model of finance and all that, that's in your favor, right? So if you go and you say, well, why isn't family practice all running this, so to speak? they'll say, well, look at the stats. It's like number one, treatment's not going to change. Number two, they massage the numbers and their stats say, well, our old test works just fine. Right. And kind of, okay, if you look at it from that point of view, okay, that's a systemic issue to control costs. That's all it is, really. If you look at it from our point of view, and really anybody, like you take any doctor, doesn't matter what kind they are, if they're trying to look at, well, how can I help this person on all fronts possible? And that means not just if they need a drug, great, but not just drugs, but like, are they sleeping enough? Are they moving their body and exercising? Is their blood sugar controlled properly? Is there other metabolism there? Do they have other reasons for inflammation? And how are their genetics impacting? Because there's a lot of genetics get involved in this, and a lot of them are silent. Like, you don't see it till you do these tests. If you're thinking about that and you're a doctor with a thinking cap on, you're gonna say, well, I would like all the data I could to let me look at those areas, right? Whereas if I just want to say good, bad, too much bad, here's the statin, eh, you know,
Yeah.
it's not, these are well-meaning people, but it's just not, in my mind, it's not the best medicine, but it makes sense for the system.
Mm.
I'll stop there. You can make as much as you want of the word system as you want to.
It's a very safe answer you just gave.
Yeah.
I can interpret that a whole
Yeah.
lot of different ways, though. It's like, but just follow the
Yeah. You
pharmacy
just
trail there.
think about the system.
Follow the trail. All right. So what I want to do now is, is talk about these labs, these detailed
Mhm.
labs,
Mhm.
we call it lipoprotein fractional labs, NMR, with the nuclear magnetic resonance testing, all that great stuff, EAPs. But you, for the most part, you're going to get some numbers spat out at you, right? And I want to take this time. The question is going to be, what do these lab values mean? But more so to the patient, right? Because they're going to get
Right.
it, and the doctor's going to say, "Here's your number, da 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 da. Here it is." But
Right.
I want to kind of, give the patient some education on what does that actually mean for you, the person looking at the labs, is worried about the long-term risk, right? We already talked about the LDL-P, the particle size, a
Mhm.
little bit about the HDL-P. So now this is the round robin here, right? This is the fun part here. So to me, at least, right? So I'm just going to go down my list here,
Okay.
right? And put my thinking cap on here. So let's start, since we're on the LDL kind of side of things, let's talk about oxidized LDL, or OX-LDL.
Yeah. So this is an area where we've been able to test oxidized LDL for quite a while, but I think accurately maybe more in the last 15 years, let's say. One of the things when I was talking about not all LDL is as bad, right, as other LDL, the smaller you get with the particle size, the more likely there is unorganized or inflammatory fat in there. But what oxidized LDL is, it takes the whole family and it says, based on, what we know about quote unquote normal particles, is this person's oxidation level higher than average, or lower than average, or is it average? And what that means is, regardless of the size, but probably more likely in the smaller particles, you have little, the LDL that's oxidized are like little packets of fire running around. It's inflammation. And it's because the lipids are oxidized, for usually because HDL hasn't done its job or something, or you've got toxicities or other things. The biggest problem is, the higher the oxidation level is, the more it's going to run into the side of your blood vessels. Blood vessel has a tissue response, and then you start to make plaque, which is what we don't want to do, right? Now, there are, it's a couple papers that like kind of throw shade on oxidized LDL, like we shouldn't do it and it's meaningless. But if you look at it in the context of the rest of this test, it's incredibly helpful, because here's the thing, and the papers that write, throw shade on it, are basically saying, well, no one's going to do lifestyle medicine, right? So oxidized LDL is one of the quickest things you can start to turn around in the average person, because that's largely affected by how inflammatory your diet is. If you're moving your body, especially your big skeletal muscle around, so movement, working out, whatever your you need to do. Also, your status of your nutrients in your body. So that's diet related, but you might need extra certain things. And then also stuff in the environment. So sometimes oxidized LDL will go up if you've had toxic exposures or something. So what I will tell patients is, look, this test, and it's usually part of these panels. Let's look at it as a baseline and let's do the simple things first. Let's get you hydrated. Let's get you moving more. Let's check your diet out, all those good things. And then if it doesn't come down, then let's look a little deeper and see, have you had toxic exposures? Have you, had maybe some genetic thing, maybe other stuff like that. So oxidized LDL, even before these tests were super popular, we would get it as like a little bit deeper look. And I really think it's worth, in my mind, it's one of the first things that can change with diet and lifestyle. And that's why this, kind of the system overlooks it, because the most you're going to get there is a handout in the system, right?
Yeah, exactly. And this might be wrong. When I spent so much time in the military, man, I always think of my ox LDL as landmines. They're active mines.
Yep.
They're active,
Yep.
right? And it's just like, you know what, since they're active, they got a higher risk of causing some damage here. But like you said, because they're active, you can find them.
Right.
And if you have a minesweeper or some kind of like mine disposal unit, you can actually get rid of them versus something that's already kind of like it's a missile that's launched, right? It's right there. It's dangerous. You can get it. You can attack it. You see it, go after it. Low hanging fruit, so to speak.
Mm-hmm.
The next one, which kind of similar but not so similar, is LP-PLA2.
Yeah. So normally when you see LP on these tests, it's lipoprotein. So that's fat with a kind of a protein. You think of it like a skeleton holding it together, right? So the PL or PLA2, that's a phospholipase. That's an enzyme activation test, basically. And what that tries to tell you is that enzyme is activated at a higher level when you're having more inflammation. Okay.
Mm-hmm.
So you've got oxidized LDL sort of at the end of the trail, like the landmines. The phospholipase A2 is up at the beginning of the inflammatory cascade. And so that's sort of like, the people who are going to go put the landmines out, right? It's literally telling you we need some inflammation for whatever reason. Now, people say, why we even have that if it's bad? Well, it's not always bad. If you didn't have that enzyme system and you got sick, you would never have an immune response, right? But we don't want to have it when we don't need it. And people who are inflamed for different reasons, people with a lot of extra cholesterol they don't need, that's just part of that inflammatory cascade that keeps going and just, creating fires everywhere.
Gotcha. Perfect. Now, the next one, staying with the lipoproteins, is LP little a.
Yes. So lipoprotein A, or small a or little a, whatever you want to call it, is sort of in the early days before these sort of tests we have now were available. It was one of the subfractions that they found. And really, the first research was all about, if I do cardiac stent procedure, where they go in, your coronary arteries are plugged up, so they put a stent in, open it up. Great. One problem with those is they'll fill back up again, right?
Mm-hmm.
So what they found was this one little subfraction that they could isolate, LP little a. If it was higher, you had more likelihood of your stent reoccluding, going bad, right? And so then they worked backward from that and said, well, that's obviously really a bad thing. And they had cutoffs for it, that were, this is good LP little a. And if it gets up to here, you're for sure going to occlude. And imagine if you didn't have stents and you had a high LP little a, you're probably already occluding somewhere, small vessels in your heart or your kidneys or your brain or something. So the higher that number is, the more it's associated with, again, the inflammatory process that causes the little fires to start and keeps them going. Okay. So it was literally something that they were able to isolate kind of in that time period between Fredrickson, who did electrophoresis, which is really old tech, but came up with really good data, and then NMRs and VAPs, which is what we have now. LP little a was kind of the first bad guy they found, I think. Yeah.
Hey everyone, thanks for checking out part 1 of this episode of the Optimization Academy. For more information on Dr. Paul Anderson, check out the links in the episode description and don't forget to like and subscribe and share this episode.